Good morning, good afternoon, and good evening to all of you joining us from more than 60 countries worldwide in this webinar. My name is Eva Garmendia, coordinator at the Uppsala Antibiotic Center and co-organizer of this series of events that brings us together today. We are very thankful that you chose to join this initiative on impactful approaches for community-wide engagement on antibiotic resistance, organized by REACT, Antibiotic Smart Sweden, and the Uppsala Antibiotic Center. We also thank the Swedish International Development Cooperation Agency, Vinnova, and Uppsala University for funding support. With this initiative, we seek to raise awareness and help promote a systematic and meaningful engagement of communities and civil society groups as key stakeholders in the global response to antibiotic resistance. It also aims to share experiences and learnings from experts in the field and explore opportunities to strengthen community engagement in the global political agenda. This initiative featured, back on the 26th of September, a first webinar presenting different approaches to community engagement on antibiotic resistance across the globe. If you missed the webinar, it is available on the YouTube channel of the Uppsala Antibiotic Center, and also can be found via the initiatives page hosted at REACT's website. Today, in our second webinar, we will dive into the evaluation and impact of community engagement on antibiotic resistance. As with the previous one, the webinar is being recorded and will be made available for sharing shortly after today. Later this autumn, this initiative will also feature a small hybrid workshop on November 29th. Where key aspects of both webinars will be discussed further, as well as exploring current challenges and potential solutions to strengthen community engagement in antibiotic resistance. And now it is my pleasure to introduce you to today's moderator, Dr. Rebecca King. Rebecca is trained in social anthropology at the University of Cambridge, and she's currently head of the Nuffield Center for International Health and Development at the University of Leeds. Rebecca leads a research portfolio bringing together her expertise in participatory community-based interventions, the importance of embedding approaches within the existing health infrastructure, and the critical need to address antimicrobial resistance globally. She leads an MRC-funded study, COSTAR, which was presented in webinar 1, and co-leads a global network of researchers and practitioners working to address AMR through community engagement, also known as CE for AMR. Rebecca, the floor is yours. Thank you for being here today with us.
Thank you very much for the introduction, and I'm delighted to see everyone here today. In webinar 1, we learned about a number of approaches to community engagement. You can see on this slide the moderator, Kirsten Eckerfeldt, and panelists from webinar 1. We heard from Camilla Bjorn speaking about Antibiotic Smart Sweden, Florence Anam from the Global Network of People Living with HIV, Daniel Warungi from Students Against Superbugs, and my colleague, Professor Rumana Haq, recorded a presentation on the work of COSTAR in Bangladesh, and due to her travel arrangements, I was available to respond to questions. Next slide, please. We had a really interesting discussion in webinar 1, with panelists being asked questions particularly around the enablers and challenges in undertaking community engagement work. Here on this slide, you can see some of the key themes that emerged from the discussion, and these included the importance of involving different parts of the community, the importance of making a case for robust financial and political investment, and the potential of embedding approaches to community engagement within existing health and other system infrastructure. Next slide, please. It's worth noting at the outset that when we speak about community engagement, we do need to clarify first what we mean by community, and second, what we mean by engagement, community engagement. In my own work, community has so far been defined in quite simplistic terms, more or less responding to the idea of the general public. And this has been quite useful because WHO provides a set of clear expectations about what the lay person can do in relation to addressing the drivers of AMR. However, my team and I, and I'm sure this will be discussed in this webinar, are very well aware that there are communities within communities and that communities are rarely homogeneous. In CE for AMR, we have defined community engagement as a participatory process through which equitable partnerships are developed with community stakeholders who are enabled to identify, develop and implement community-led sustainable solutions using existing or available resources to issues that are of concern to them and to the wider global community. But again, there's no fixed definition of community engagement, and we'll be exploring different approaches to community engagement here. Today, we're focusing on evaluation of community engagement approaches. This is something that I found very challenging, and I'm really looking forward to today's discussion so that I can hear from other colleagues about their approaches. When evaluating our work in COSTAR, there are more than two main areas to consider. One is the evaluation of the process and experience of engagement itself. This in itself is really challenging, and I don't think we have the answers by any means. We are really interested in each element of the intervention development and implementation, and exploring how collaborative and participatory it has been. And we're exploring this, for example, through the observation of the interventions, reflections from the research team, and focus group discussions with participants. However, the other area for evaluation is, of course, the impact of a community engagement approach on antimicrobial resistance itself. My view, which is not always shared with all my colleagues, is that we may not see substantial impacts on levels of resistance from community engagement interventions alone. Rather, the work that I do, in my opinion, is part of a much wider set of interventions and initiatives that need to be undertaken together in order to impact on resistance. So these include, for example, training human and animal health workers to appropriately diagnose and prescribe antimicrobials, and/or environmental interventions to prevent the circulation of antimicrobials and antimicrobial resistant microbes in soil and water. Therefore, one challenge is convincing funders and policymakers of the validity of approaches where the evaluation is sometimes focused on intermediate outcomes, such as knowledge, awareness, practice. And moreover, even measuring behaviour change is very challenging in the context of the places that I work. So, for example, it would be very helpful to assess if demands for antibiotics has reduced, but sometimes routine records do not allow this. So in our group, we've spent days and weeks and months discussing options and often come back to the answer that this is a challenging area. So as I say, I'm really looking forward to hear from panelists today on their experiences. Next slide, please. So we're going to hear from our panelists in a moment. In the first webinar, it was noted that if you can't measure it, it never happened, which might be a feeling that we're all familiar with. And we should be aware of the importance of measuring and reporting our successes as well as our failures. We measure impact both to evaluate success in addressing public health issues, as well as to engage with key stakeholders, influence policies, and create programs that are based on the needs of communities. Today, our expert panel will discuss the indicators that previous and/or current initiatives have used to evaluate community engagement initiatives. Slide 7, please. So our conversation today will feature 4 short keynotes, and it will be followed by a panel discussion, and then we will finish with a Q&A with questions from online participants. I'm going to introduce each of our speakers before their own presentations, and I would like to begin with Satya Sivaraman, who is currently the Communications Coordinator for REACT Asia Pacific. He's been with REACT since its inception in 2006, developing communication material, key messages, and networking with civil society groups. Satya is a journalist with over 3 decades of experience in newspapers and TV channels in South and Southeast Asia. He has also worked with the UN Economic and Social Commission for Asia Pacific and other UN agencies in different capacities. Thank you, Satya.
Thank you, Dr. Rebecca. Shall I start sharing my screen?
Yes, correct, Satya. You can now share your screen.
Yeah. Thank you. So my presentation today is about a project we did in the southern part of India in a province called Kerala, which is called the Antibiotic Smart Communities. And the broad purpose of the project was to see if we can measure the antibiotic smartness of a community. The idea being that when you intervene in a community, you start off with an understanding of the baseline as to where the community is at that particular moment when the intervention is happening. The question was, how do we know what the community knows? How much does it know? And because it's based on that baseline understanding that you can do interventions to improve their understanding, or interventions that can help improve whatever the status of the health issues there are at that moment. So this was broadly motivated by the fact that national action plans, which countries around the world have adopted since 2016 or so, are very broad. And in a country like India, for example, which is a vast country with a vast population, very diverse context, adopting a national action plan at the national level has no particular meaning at the subnational level at all. Because by the time it gets so diluted and the contexts are so varying, that there was a need for something at the local level or at the community level in particular. So we decided to do a pilot project. It was a learning process for us also, because there are no real models to go with. The broad criteria that we, or the approach that we took, had 5 different elements to it when we were designing the project. One was to unpack the issue of AMR, because AMR, antimicrobial resistance, is not understood very well, even in, I would argue, in expert context. So very difficult to expect it to be understood at all at the community level. There's so many other competing health issues, and health in general is a mysterious thing for many people. So the first step was to unpack the issue. Second was to see how much of the local resources could be mobilized if it is to be owned by the community. So there we sort of worked on identifying the community assets that could be co-opted for the project, especially engaging local self-governing institutions. In the context of Kerala, in southern India, where the project was done, there are very strong self-help groups run by women, which were involved in this project. And there are also strong decentralized local government institutions. The last step was to frame the metrics for measuring success. That's where we basically focused on developing these indicators, which I'll come to subsequently. The initial period was, of course, of the project was to actually map out the community of around 15,000 people, roughly 11 to 15,000 people, doing surveys, understanding what are the needs, local health needs of the people, in the context of not just the AMR, but also in general. Because when you go into a community, your concern may be antimicrobial resistance, but that's not the priority of the community. So the idea was to understand what their needs were. And we also took the approach that antimicrobial resistance anyway is driven by both AMR specific and AMR sensitive factors. There's a very wide range of factors that drive AMR. So it is important to take into account a broader range of things. It cannot be just purely medical aspects of whether it is the infection prevention control or moderation of antibiotic use or looking at over-the-counter prescriptions alone. So we looked at broader issues also, and we did these focus group discussions with people apart from household surveys and mapping of non-domestic antibiotic use sites like clinics, retail pharmacies, poultry farms. These are all, this community, Kerala in particular, has a very high rate of urbanization. So it's quite different from other parts of India in that sense. So it's a mix of both the urban and the rural, even in the so-called rural areas. So you have farming going on side by side with more modern professions, modern activities, economic activities. So using the insights from the community engagement, there were these expert consultations we organized for public health professionals, veterinarians and agriculture experts, and development practitioners who also work on environmental issues. And we looked at the SDGs, the Sustainable Development Goal indicators, also to see which of those indicators could be used for measuring antibiotic smartness. So in the initial round, a list of almost 34 indicators, along with measurement strategies, were framed. Now, we took what is called the One Health approach, which is look at the human, animal, and environmental health issues all together, not focusing on any one of them alone. So we came up with 34 indicators, but it was felt that 34 indicators was simply too large. So we subjected these 34 indicators to another round of prioritization by 20 global experts, and looking at three criteria: appropriateness, sensitivity to changes, and feasibility of collecting the information required to see the indicators, to measure the indicators. So the final framework of 15 indicators that we came up with covered health, hygiene, animal health, environment, development, and multi-sectoral kind of domains. And these indicators and the methodology for applying them or measuring them was published as a handbook. Now, the set of indicators, I won't read all of them, but there were 15 of them. And just to give some examples: hygiene facilities in primary and secondary schools in the community, proportion of households having individual household latrines with water supply within the premises of their house. So these are all sanitation and wash kind of indicators. Then access to pediatric vaccines listed in the actual coverage of pediatric vaccines in the immunization schedule. Percentage of access antibiotics in total antibiotics, access antibiotics as in the aware classification of WHO, in total antibiotics dispensed in outpatient settings, over-the-counter availability of antibiotics, proportion of population using safely managed drinking water services, availability of veterinary lab services for disease diagnostics. So we took into account veterinary, human health, and the environmental issues in terms of, for example, even proportion of wastewater treated using any established wastewater treatment technologies as per WHO guidelines. Each indicator...
Thank you so much. Could I please ask you to wrap up in the next minute or so? Thank you so much.
7 minutes? Okay. Well, these were the 15 indicators, and each indicator there was a system to measure the score depending on performance. And so the idea was that we had these indicators and you could go into a community and measure the score of that community at that particular moment, and then followed up with an action agenda where we designed interventions to help the community improve their scores. So this is essentially an example of that was, for example, creating compost pits for toilets, how to do that. So the indicators gave us a basis to design interventions, which were then taken to the community. So this was a framework that we thought was useful, because when we did the interventions and measured again that the scores had improved, because there's a lot of scope for improvement in how these indicators are framed. It will depend on the context also. We actually piloted these smart community indicators in around 5 locations around India, and currently are in the process of piloting them in Indonesia also to test them out in different contexts. Broadly, to wrap up, this indicator framework we found very useful because it has measurable actions or you can measure the status of antibiotic smartness of the community. And we thought this is a very useful way to move forward in addressing AMR in an actual community setup. And the broad purpose of this exercise was to be able to do not just bottom up, but also to be able to feed top down processes, because both top down and bottom up approaches are important. It's not an either or situation. The intelligence gathering that we can do at the community level through this indicator framework can feed into the policy process. And that this two-way kind of exchange is very important. I'll come to that later in the discussion. Thank you.
Thank you very much, Satya. That was really fascinating, and I'd really like to hear more about your work at some point, and I'm sure we'll hear more in the panel discussion. So as our next speaker, I would like to introduce Dr. Shonali Johnson, who is Head of Knowledge, Advocacy and Policy at the Union for International Cancer Control. Her main area of work is to ensure that cancer prevention, treatment and care is positioned within the global health and development agenda. Shonali has worked on a range of public health issues, including gender and HIV/AIDS, reproductive and sexual health, and gender-based violence. Shonali holds a PhD and postdoctoral diploma in public health and policy from the London School of Hygiene and Tropical Medicine. Welcome, Shonali. Thank you.
Thank you very much for the introduction, Rebecca, and thank you very much for inviting me on behalf of the Union for International Cancer Control. Just very quickly, because it's important to the community that we will be discussing, the Union for International Cancer Control, the UICC, is a membership organization. Our headquarters are in Geneva, but we are made up of more than 1,100 members in 170 countries around the world. And our members include cancer societies, hospitals, patient groups, ministries of health, and foundations. So actually, I would like to just start by talking about the community I will refer to in this presentation and in the discussion. So UICC sees itself really as representing at a global level the advocacy agenda of the cancer community. And by cancer community, we mean our members, which refer to the broad sector that I have just mentioned, but also those with lived experience in countries who are represented by patient groups that make up a large number of our members. So the community that we really target is the cancer community. So those are people with lived experience of cancer, so patients and their families and those affected by cancer, but also those providing cancer care, so oncologists, health professionals, nurses, doctors, etc., palliative care workers. So this is the community that we work with and that we have been working for the last about 6 years to sensitize on the issue of AMR. Oops, my computer, okay. So before I get into the challenge of AMR and why we felt that it was really important to sensitize the cancer community to the problem of AMR, is that cancer is growing. If you look at the trends between 2012 and 2030 in terms of new cases, you'll see that there's a huge growth from 8.2 million deaths and 14.1 million cases to a projected 12.9 million deaths and 24.6 million cases. And we see a rise in incidence in cancer all over the world, but we also see a corresponding rise in mortality, particularly in low and middle income countries where you have less cancer services available, or you have a fragmented service with less effective cancer therapeutics or diagnostics and care. So it really is a pressing global problem. But it's very important to cancer patients that we really get on top of the AMR crisis. And why UICC became engaged with this topic really a lot more in 2018. From 2018, we really began to step up our efforts, because we could see that as many as 1 in 5 cancer patients undergoing treatment are hospitalized due to infection, and that infection is a second leading cause of death in patients with cancer. Cancer patients have a tendency towards neutropenia, which is a low neutrophil count, a type of blood, white blood cell, which makes them susceptible to infection. And antibiotics themselves are critical for across the cancer journey, but particularly in those cancers like leukemia and lymphoma, and also for treatments such as stem cell transplants and bone marrow transplants. So it is a really important issue, and that has the potential to set back advances in cancer treatment and care by 50 or more years. So this is something that the cancer community needs to get on top of. The issue that we had seen when we started to work on this with our community is that levels of awareness in cancer, in AMR, were low. And this is also among our patient groups, but also oncologists and others working in cancer. It was seen more as an issue for infectious disease communities rather than the NCD community. And we've been working really to change that perception. Particularly, we have been looking at case studies. It hasn't been so easy to be able to get case studies from patients who have cancer. But here is one more positive case study about Helge, who had a stem cell transplant and was able to have antibiotics, and the antibiotics actually saved his life. And he and others become really strong advocates for the importance of antibiotics as part of their cancer care. But here is a very sad story about Matilda. Her name has been changed, which was told to us by one of our pediatric oncologists, who was a 9-year-old girl with cancer who had failed her initial treatment protocol and was getting more aggressive treatment, and then was actually responding well to the treatment, but soon deteriorated due to an ongoing fever. She had an increase in heart rate. Her blood pressure dropped very quickly. She had a lot of medical issues very quickly, and unfortunately Matilda passed away. And the blood culture taken showed that it was a gram-negative bacteria, it was Klebsiella, and that it was resistant to most antibiotics, including the ones that she was receiving. So Matilda's case, unfortunately, is seen in many cancer patients, particularly in low and middle income countries, and also in pediatric patients. So it is a topic that, as I said, is gaining a lot more traction in the oncology community. 95% of oncologists surveyed in the UK are worried about AMR. This was one study that was conducted by the Nuffield Trust, part of a longitudinal prize report. And almost half of those polled said that they believe drug-resistant infections could make chemotherapy unviable in the future. Our work has therefore, for the last 5 years, and I'm going to talk more in the panel about the indicators that we would like to see more externally, that we can track the response to AMR within the cancer therapeutic settings, is we have been focusing on awareness raising within the community. So we, through our communications campaigns, we have done mini campaigns, we have done webinars, we have sent out a series of written communications, and we look at things like click rates, open rates, we monitor discussions and dialogues among the communities. There are advantages and disadvantages of these. We can capture a lot of quality rich information, but in terms of more representational information from all of our members, it has been quite difficult to get. And of course, there's survey bias and other issues in collecting that kind of data. However, from what we have seen, we started an initial survey when we began our AMR work to see how many of our members were interested or even knew about AMR, and we have seen an uptick in information and awareness. So the three policy asks that we are now working on in terms of our work, and we have an expert task force, an AMR task force to guide us, made up of the cancer and AMR and infectious disease community, are the data collection and surveillance, because we want to collect data on the impact of resistant infections on cancer patients, access to treatment. So here we're focusing on access to quality assured medicines and diagnostics. Diagnostics for for infections is critical, but also R&D for new medicines and diagnostics. And then we want to look at the streamlining of AMR international policy documents, and that can also provide us with a whole new set of indicators For example, we are doing a review of national cancer control plans, and we have included a question on AMR in the review questionnaire to see how many countries are already including it, and then to focus more on closing that gap. In terms of engaging our cancer community, we've been looking at master courses, communications, campaigns, virtual dialogues, sessions at our congresses, side events at the World Health Assembly. We plan to do that to engage more member states. And we will be working now towards the UN high-level meeting on AMR and involving our members. So our call to action really will be that the cancer and infectious disease communities have to come together to better address the threat of AMR for better cancer treatment and care. Thank you.
Thank you very much, Shonali. That was really, really interesting, and it's an area that I think most people working in AMR are very much aware that AMR impacts on cancer care. So it was interesting to hear more and the work that you're doing to integrate the two areas. Thank you. So our next speaker is Professor Diane Ashiru-Oradope, and she is the lead pharmacist for healthcare associated infections and AMR at the UK Health Security Agency and Deputy Chief Scientist at the Royal Pharmaceutical Society. She is Honorary Chair and Professor of Pharmaceutical Public Health at the University of Nottingham. And in 2014, Diane created the Global Antibiotic Guardian campaign. From 2016 until March 2022, she was advisor and global AMR lead for the Commonwealth Pharmacists Association. So welcome, Diane, very much looking forward to your presentation.
Thank you. Just checking that you can see the slides.
Yes, I can, but it's not in the slide.
I will change it now. So hopefully you can do that right. Okay.
Yeah, thank you.
Okay, so over the next few minutes, I will be sharing with you an online platform that was created, which is the Antibiotic Guardian campaign. And that's how we've used that to catalyze action and behavior change across several groups. So for us, our community is broad, but yet actually tailored. And I'll take you through how we've got to where we are. What I'm going to share with you is a journey of 10 years. So there's a lot of information to get through, and I've got a short period of time, but hopefully you will get the sense of what the approaches we've taken, and then I can answer further questions during the panel discussion and the Q&A session. So the Antibiotic Guardian campaign, which I've been asked to talk about, was launched in 2014, and it was launched as very much part of European Antibiotic Awareness Day. We have a range of, it is one tool that we have across our professional and public education engagements and training, tools and resources and activities within England and across the UK. So in developing plans for EAD 2014, we wanted to move beyond the day. So many will know that EAD existed. So that's the journey of how we got here. And we thought, how do we move and catalyze action that goes across the year and not just where we have focused attention on the 18th of November. And we wanted something that was available all year round, and also to go beyond awareness. How do we see who is interested, who wants to be engaged, and who wants to take action? So that's the process that led us to what then became the Antibiotic Guardian campaign. There was no funding available, and it was 2014. The approach we took was considered risky and novel at that point. Many of us will now see that as very, very normal, what we do. We had a planning group, so it talks about creating it. It was very much me leading and working with so many colleagues across the 4 UK nations that we have. And we had a multidisciplinary group that I was chairing at that point and taking that through different governance processes. So when we developed it, we have a video on the website. That video really focuses on the public. However, we do have, as you can see on the right side, 3 core communities that I guess we focus on. So we've got healthcare professionals and leaders, members of the public, and then students and educator. And we use the TV doctor at that, to help us record a video that gave key messages to the public, and then an action that they could take, which was choose a pledge and become an antibiotic guardian. As I said, there was no media funding. There was actually, the website was initially gifted through the British Society for Antimicrobial Chemotherapy as a test and a pilot of what could happen. And it's a One Health approach. So we have pledges for human health, the focus on human health as well as animal health. And so within the 3 groups, and I'll go to another page now, which shows you even within those 3 communities as they are, we have even more narrower communities within that as well. But it started off as a national campaign and then became global. And it was developed using behavioral science, the approach, the if-then implementation intention. So that's where people in advance say what they would do in a particular situation. And you'll see how that translates through some of the pledges as I share them. So as I said, several communities, but tailored information, and it's always on across the year. And then we had then started to build collaborations with WHO Europe, Africa CDC, and then within specific countries as well, South Africa, Nigeria, and Belgium, and then national AMR groups. And you can see there that the image of the world and where the pledges are was actually taken a few years ago, and things have moved on since then. So some examples of the groups that we have. So within the healthcare professional groups, we have pledges for pharmacy teams, nurses, midwives, veterinary and nursing teams, primary or secondary care, other healthcare professionals, so the allied health professionals, radiographers, we have for dentists, we have for specialists as well. And then for the public, we also have pledges for pets and horse owners, farmers, family members, those are families, and then adults as well. And you can see example of what I mean by the if-then approach. So if my vet prescribes antibiotics for my animal, I will follow the instructions provided and I will not change the dosage or stop the therapy. So that's in advance saying, if this happens, I will take this action. We also then have pledges for students, educators, and scientists as another group, and you can see examples of those pledges there for them. We have a whole range of resources available through the website, but also through our World Antimicrobial Awareness Week toolkit that we work on each year and publish for healthcare professionals to use in, so usually specialist healthcare professionals to use in educating others as well. We also have patient stories on the website, and 2017, we actually had a mass media campaign, which was called Keep Antibiotics Working. And that was slightly different because that was focused on the members of the public that didn't even know why they should care about AMR. In terms of evaluating our campaign, we really focused on evaluation very, very quickly from the first year. And I know Rebecca was talking about different approaches for evaluation. We have done process evaluation, impact evaluation, qualitative evaluation, and each year we have the key results from that year published in our national surveillance report for antimicrobial utilization and resistance called SBAR. So in terms of impacts, we looked at the self-reported knowledge and behavior change that colleagues reported. And we also, when we collaborated with WHO Europe, did both the impact in terms of knowledge and behavior change, but we also analyzed the AMR knowledge data. Because once you finish your pledging and click, there are questions that come through, which are knowledge questions. Am I 7 minutes over already?
1 minute left.
Okay, fine. I did time myself, so I'm looking at the screen here. And you can see an example of what people say here, that the campaign increased commitment to tackling it. So from an evaluation, increased commitment to tackling AMR in both healthcare professionals and members of the public, and increased self-reported knowledge and changed self-reported behavior as well. We also take an approach in terms of social media. We use social media quite actively, and we encourage others to. So not from us who are developing, but everyone else. And you can see a wide range of images that people have shared across social media, engaging children, also going into care homes, communities, pharmacies, universities, just a wide range. We also engage with students, and again, we've analysed and evaluated our healthcare students conference that we do. And there are students that then taking action because we've catalyzed and encouraged them to start. So for example, UCL in London, the students, they have created multilingual videos on AMR messages that is available for all to use. We have the Antibiotic Guardian Schools Ambassador, and that's the way we're engaging with scientists and healthcare professionals who are not specialists and encouraging them to go into schools to teach about AMR. So we provide them with tools and resources, everything they need basically to make that easy for them. We also have our shared learning and awards to reward those who participate, and we do that through virtual, or we've gone back into physical awards now where people can again share what they've done and so that others can learn from them. And we have those available on our shared learning platform. Just going back to the evaluation. And so again, examples, our core bit is a number of pledges, and you can see how that changes over the years. We've been able to get it into policy, and you can see in 2020, that was an example of where policy made a big difference around number of pledges and people pledging. We also ask for organizations to choose their pledge or to register their activities, and you can see there that more than 900 organizations over the years have registered their activities. This slide here just shows the pledge groups and the number of pledges we have. You can see pharmacy teams are the highest. That was always the case, but because of the policy intervention that we had, that increased significantly. And then students, members of the public are the third group, but you can see we've got something for all there. And then just mention eBug very quickly, and that's the way we engage broader with students and with young people, and that works in collaboration with Antibiotic Guardian. This slide here is just to show that, you know, that colleagues are doing this across the world, but you can see an example there in 2022, we had 169,000 pledges. As of the time when I took a screenshot of the page, or went to take the pledges, and where I was creating this presentation slides, we'd gone to 193,000, and that's just over a year. So pledges are going on throughout the whole year. That's me, thank you.
Thank you so much. That was absolutely fascinating and clearly, you know, having huge impact. Thank you. So our final speaker today is Professor Till Bachmann, who is the Chair of Molecular Diagnostics and Infection at the Centre of Inflammation Research at the University of Edinburgh. Till is the AMR Strategy Lead for Edinburgh Infectious Diseases, Chair of the Edinburgh AMR Forum, and co-director of the University of Edinburgh's Fleming Fund Fellowships Host Institution Programme. He's also the coordinator of the UK-India project DOSA, Diagnostics for One Health and User-Driven Solutions for AMR, and fulfills a range of industrial and institutional advisory roles worldwide. So over to Till, thank you.
Thank you so much, Rebecca, for the kind introduction, and Eva and the colleagues for the invitation to speak today. So yes, I have been asked to speak about the DOSA project. DOSA stands for Diagnostics for One Health and User-Driven Solutions for Antimicrobial Resistance. And I think it fits very well into today's session because it takes a very innovative approach, or a different approach to what we are used to from diagnostics. So the DOSA project has two phases. So the big one at the beginning to lay the foundation on the project is shown here to recognize contributions. So it's a UK-India project, which we had with overall 10 partners, 4 in the UK and 6 in India. And what we really wanted to do here was an addressing of a One Health problem with diagnostics, AMR, One Health issue with diagnostics, but take a different approach to what is usually done. And this is next slide shows the need for infectious disease diagnostics. And I presented this at the launch of the WHO Global Research Agenda for AMR. And it's a really good depiction of the situation which we have with rapid diagnostics. And it is addressing the community. So if a community member is ill, they need to access healthcare, or usually access healthcare. And at the healthcare center of what kind it is in the respective setting, a rapid decision needs to be made in order to start therapy. Current diagnostics are too slow, and in essence, they are too slow to inform therapy decisions or other decisions made with regards to healthcare made by the prescriber at the healthcare center. Now, this is why we need rapid diagnostics. Now, the issue is that almost half of the global population has little to no access to diagnostics, as it was shown in a recent, or published in a recent study by the Lancet Commission on Diagnostics. So there's a problem of access to diagnostics. There's a second problem in there, and this is the community member needs to access healthcare in order to access diagnostics in the first place. So we were looking specifically at this center here, at this situation here, in order to address this issue. So we came up with this principle here, or with this approach, where we took an objective on 3 different settings: in the human, in the dairy, and in the aquaculture setting, as a One Health situation. So human, animals, and the environment, the aquaculture as the environment. In there, we looked at urinary tract infections, mastitis, antimicrobial resistant pathogens, and antibiotic residues, which we want to detect with diagnostic assays. Now, we started this with user mapping studies and AMR baseline assessments, as you would do. So we employed a double diamond approach to this project, by which we, at the beginning, in the discovery phase, we did this user mapping and the AMR baseline assessment in these 3 different settings, as you can see here. So we provided baseline assessment, design, ethnography. Now, what was challenging in this project, and slightly different to previous ones which I did, was that we had a huge portfolio of diagnostic technologies which we had in our respective groups, which we needed to bring together and address the user needs which we had identified in this very beginning. And this led to a creation of so-called target product profiles, which are reflections of these user needs. And then we went out and tested these target product profiles, or the prototypes, so in the development and then in the delivery phase. Now, as I said, we started with the field work and the understanding of the situation of people on the ground. And what I'm showing here is the situation around the urinary tract infection. So we did a lot of field work where we engaged with community members, but also with the ASHA, so with the healthcare community workers in the setting in Assam, in India. And what we identified was that the key issue with the approach to urinary tract infections was the awareness around urinary tract infections as an infection, and the connection of UTI symptoms with the infection, and the access to healthcare. So the care-seeking behavior as a means to address the urinary tract infections was a key item which we have identified. So in collaboration and close engagement with the community, we came up with a different design to a diagnostics intervention. So we had, as it's shown here on the top left, is that we had numerous rounds of co-design sessions with ASHAs at primary healthcare centers in Assam. We had workshops in Edinburgh around the target product profile development. Going back into the community, had real-life walkthroughs with feedback from the community in order to refine those designs of the target product profiles. And then, of course, we had a close engagement with the local and state health authorities. Now, what we came up with, in short, was that these tests would need to be possible to be done in the community. So not in a healthcare center, but in the community. So basically a home test, provide meaningful information. So what can that information be so the individual can act on? It needs to be obviously easy to understand, operate, and dispose as you are operating in the community. It needs to have low costs. And then for a diagnostic developer, always challenging, it needs to be environmentally stable. So basically, this is what we came up with. It's a combination of a diagnostic tool, as you can see here on the right, with a lot of healthcare information. So raising awareness of AMR, but also raising awareness of your own health. So as you can see here, for example, identification of symptoms and connecting them with urinary tract infection, because as you can imagine, UTI is a sensitive topic, so you can't just speak about it, or often you can't just speak about it. So pointing at symptoms is one thing, and depicting those symptoms is a way of communication. And then there's a guidance on how to act on these results. And what we can see here also is that we are also looking into a data capture system in order to make those results available. Now, what this test does is it provides a system strengthening, as can be seen here. So this is the situation before. So the individual is basically lost in its interaction with the community, with the healthcare system, but we can strengthen the system and make those connections more visible and more straightforward. we will talk about measuring impact and measuring the impact of the community engagement. We clearly saw that there's an amplifying factor by our engagement coming from the feedback which we have. So what we have now is that we are now doing a trial where we investigate if the test is actually doing what we are promising under the conditions, so a field trial of performance. And I show these pictures because they clearly demonstrate the response which we get on this, because we hit a clearly unmet need by the community, and as such understand or have the feedback that the approach to diagnostic design as we took it here is addressing the right one. And with that, I thank you for your attention, and I'm happy to take any questions in the panel discussion. Thank you so much.
Thank you very much, Till. That was really interesting. It's such an important area of work. So prior to starting the panel discussion in a moment, I would like to encourage the online participants to use the Q&A Zoom function to ask questions to our panelists. Please write your name and specify whether you'd like the question to be asked to a specific panelist or to the whole panel. And we will select a few questions and ask them in the Q&A session after the panel discussion. Thank you very much. I'm going to start with a question and put it to all of our panelists one by one. The question is, you have each shared with us approaches to community engagement and AMR. So I'd like to ask you, there's two parts to this question. First of all, what do you consider success to look like in the approach you have presented? And related to that, what do you think are appropriate indicators to measure in community engagement approaches? So what is success for you, and what are good indicators to measure? And I will ask that question first to Diane, please. Thank you.
Thank you, Rebecca. Can you hear me okay?
Yeah.
So I think I'm probably going to, I'll mix the question, and I'll share how within ours it fits in. So for us, increased community participation. And as I shared, we have multiple communities that we're trying to reach. And so for us, being able to know that we're reaching those groups, and pharmacy teams were a really good example for us, where we've been able to follow through from them being naturally more engaged in the UK with AMR because of the medicines aspects to antimicrobial use, but then actually being able to put that into policy as well. So that was that they were incentivized to do a range of antimicrobial stewardship activities, and one of them was also to choose a pledge. And we've evaluated that as well to see what the impact of that was. But what was really good is it wasn't just pharmacy teams, it wasn't just pharmacists and pharmacy technicians who were pledging, but also the drivers who deliver medicines to patients. And then thinking about positive social impact, as I've mentioned, there's no funding for us. So really the indicators of success for us is that engagement. We have a hashtag we use, and we use that hashtag consistently, and I've done since 2014. So hashtag antibiotic guidance is really great when people are using that hashtag alongside any relevant AMR tweets or Facebook posts or social media posts that they're having in there. We're empowering the community members. So what it does is that people feel like they have something to do. So with the pledges, sometimes initially with AMR, we found that what happened was that people felt, we told there was a lot of, this is what will happen and it's all bad, and people didn't feel like they had something they could do. But by giving people, actually, you can choose something that you can do and contribute to tackling AMR. And then we also have the collaborative partnerships that really have been really important for us, particularly going beyond the UK. I've got a few more, but I'll stop there for now because others may pick up on that.
Thank you very much. Really comprehensive response. And if I could please ask the other panelists to also turn on their cameras so that we are all visible during the discussion. I'd like to ask Shonali, please, to give your response to this question. Thank you.
just to clarify, can you just repeat the question so I make sure I know? Okay.
Yeah, sure. It's a two-part question. So the first part of the question is, what does success look like to you in terms of the community engagement approach that you have presented? And secondly, what do you think are appropriate indicators to measure generally in community engagement?
Okay. So I'm going to focus my response on one key aspect that we're looking at, which would be a great success, certainly in the oncology community, and that would be guidelines for cancer that include AMR in them. And the reason being that these guidelines are really, they're available in some high income settings, but not around the world and not in low and middle income countries. And it's really important that all health facilities around the world, certainly health facilities, sort of tertiary, these are mainly tertiary facilities dealing with more complex cancer patients, inpatients, particularly, and they need to have these resources that promote antimicrobial stewardship. And these resources are unfortunately not available. So hospitals need to go to NICE guidelines or NCCN guidelines or other guidelines that are available, but they may not necessarily be tailored to those settings. So what we would really like is to see more, we would like hospitals, our hospitals that we work with that are part of our membership, but cancer hospitals more broadly, to already have guidance in place with regard to antimicrobial stewardship. The other thing that we would like, so we can capture that quite well in an indicators. If we do a survey, we would be able to ask if guidelines exist and you know, what kind of stewardship policies are in place, etc. But the other thing that we would like is there to be antimicrobiograms used in hospitals. And we know that in many hospitals, they are not used. They are used in, and even in hospitals where they are used, they're not updated regularly. So they may be updated every 6 years or 8 years, but you know, resistant infections move very quickly, so they really should be updated much more regularly than that. And so we would want that those in place so that you can monitor. Basically, they are a sort of table that monitor infections and provide a profile of infections, and they help with clinical decision making, and they also help you monitor resistant trends. So we think it's a very useful tool. So that's another indicator. And there are ways to link that to surveillance, and we are starting to look at a more integrated approach to these things. So I think in terms of these practical tools, that would be an ideal scenario for that to happen at the clinical level. I've already talked about the awareness, so that's just to focus really on the clinical management of cancer.
Thank you so much. That's very interesting. And Satya, I think you've already given us a really comprehensive overview of indicators, but it would be nice to hear more from you, and particularly what you would see as success in the work that you presented. Thank you.
Thank you. As the presentation I made showed very clearly, we started off exactly answering the two questions that you asked, which is, what are the indicators we need to measure the antibiotic smartness of a community? And what are the interventions that can be designed around these indicators to help the community improve its score along these indicators? And we, from our work in AMR for quite some time, know that antimicrobial resistance is a function of multiple factors, in fact, a very wide range of factors. In a low middle income country, you have very, very basic problems, which has nothing to do with actual antibiotics per se. You have lack of sanitation, you have lack of clean drinking water, you have lack of access to healthcare itself, plus the context itself, there's malnutrition, so there's a context where diseases are constantly being generated by the context itself. So you're dealing with very, very basic issues in many parts of South Asia in particular. And there we decided to take a very broad approach. So some of the indicators that we have chosen are about access to medicine or availability of antibiotics. Some of them are about access to healthcare services in general, but many of them are more broader social drivers of AMR or environmental drivers of AMR. So these indicators that we have, we came up with a scoring methodology to be able to go into the community and decide what is the score you can assign for a particular indicator in that community. And then based on the interventions that we design, which will vary according to the context, because in India itself, the context vary quite widely. So depending on the context and the indicators, we score them, and then the interventions that we design over a period of time help us improve. And that's the success part of it, that we can improve these scores. We have not kept any indicator as to the actual rates of antimicrobial resistance itself, because that is a really long-term issue. And secondly, in a particular context, irrespective of what is happening in the context, the rate of resistance in that community is not dependent on the community alone, because resistance is something that spreads across the globe. We have parts of the world where there are no antibiotics used at all because of lack of access to antibiotics, where the rates of bacterial resistance are very high. So we are not measuring our success in terms of actual impact on AMR per se, but we are looking at the factors that drive AMR and using them to measure success.
Thank you so much. Really interesting. Thank you. And finally, Till, what's your response to that first question?
Yeah, thanks, Rebecca. So it's really interesting because the funding we got for this project was an AMR funding. So what we started with was clearly that we thought we'd do something on the reduction of AMR, tackling it in primary care, and providing a high-tech or more technical solutions there. And quickly it turned out it's actually not an AMR problem, it's a health systems problem. People not seeking care-seeking behavior, and possibility to access healthcare, that's the issue. So we cannot have a technical solution and change improve the patient situation and for the patient benefit. So something needs to be done differently. And I'm really pleased by how we do it and the feedback we got. So the aspect of what is success are twofold. One is, of course, I'd like to see the diagnostics being used and adopted. So that would be a clear outcome. The diagnostic being used as a technology and that contributing to the patient benefit. That would be a success. And it would be a success also because it demonstrates that you need to involve the individual, the community, the user who is in the community in the design of these diagnostics. The conventional approach is different. The conventional approach is you interview some healthcare professionals and then those feed into the diagnostics design. So getting the community input in something very tangible like a diagnostic test would be great to show this and demonstrate this by the implementation and the adoption of the diagnostics. It's a big topic, and diagnostics adoption and use is a separate story from, or it's on top of this one here. Now, the other aspect is successes. Of course, we want to improve patient situations and patient benefit of the interventions with regards to UTI. And it's not necessarily that they get access to antibiotics. It may be, but it may also be in the prevention side. And what I've mentioned in there is that we are also capturing data on urinary tract infections. And you would be surprised, probably not in this audience, but we're meeting so much resistance with regards to considering UTI a serious problem. And for me, a success would be if we, with this project, in collaboration with others, of course, raise the awareness of urinary tract infection. It is not an uncomplicated business. It is quite complicated if you're in the community. It can be very, very impactful and is. So if you raise the awareness by collecting data in the community, which is surprisingly scarce, as you start looking into it, that would be a success. And turning that into further interventions and also in other settings. So we're looking into implementation in other settings and in other countries. And I'll stop here.
Thank you very much. And I agree with your point about it being a health system problem and other systems problem as well. Thank you. I would just like to remind our audience, please do use the Q&A function if you have questions that you want to pose to any of our panelists. Please say who you would like to respond to the question, and we will come to your questions in a few minutes. So I now have a question. specifically for Shonali, please. And that question is, what do you consider the main challenges to be in terms of evaluating and measuring the impact of community engagement approaches?
Right, so again, my community is the cancer community. That's my focus. So one of the big challenges has been typically cancer is recorded through a cancer registry. And our focus has been on really expanding the coverage of population-based cancer registries. And that has been the focus of the cancer control community, because actually cancer registries themselves are not found in all countries, and they use hospital-based registries, not population-based registries, which give you a real sense of incidence and trends in cancer. And the reason I say that is that they do not collect information on infections. I mean, when I started to do this work, I actually tried to find registries that did, and I even went to the SEER cancer registries run by the NCI, which are considered to be the CDC NCI cancer registries, which are considered to be the most complete registries. And they do record it, but it's quite complex how they do. Basically, there's quite a lot of resistance in the cancer registry community to start recording information on infections because of the data. Also because getting a registries up and running, the main indicators that you need to collect are type of cancer, your demographic information, stage at diagnosis, mortality, etc. And then you of course have to collect all the different codes and so on. So when we started to open this up, I think it's probably not going to go anywhere for many years. So we're starting to now look at another way of collecting information within the cancer community, and that is again through integrated management systems. So then using, for example, the microbiology databases to inform cancer registries, using the hospital databases. So really being able to collect in an integrated manner, also the antimicrobiogram, which I have just mentioned, being able to have an integrated set of indicators that can provide a profile in a district or in a country around what's happening in cancer. There are some pilot efforts starting that we're starting to talk to some companies and some organizations and hospitals doing that. Big hospitals like St. Jude's in Memphis, Tennessee, they have a very strong surveillance program. But again, it's taking those best practices and putting them in different contexts, which is important, especially when surveillance and data management is so variable in different countries. So I would say our really big challenge is data.
Thank you very much. It's not an uncommon challenge. Can I ask if any of the other panelists have anything they'd like to add to that?
Yeah. So I think for us, what we is maybe it's similar to data, but it's proving return on investment. Has been economic evaluation, proving return on investment, because that's one that we ask quite a bit now around, especially where we're trying to engage with the public or trying to do public campaigns, is how do you prove that what measures do you have that will then translate to return on investment? So and by that we mean when you're raising awareness, how do you show that change in behavior directly reduces resistant infections or reduces the risk of people having infections? So that's one of the things that we're particularly grappling with at the moment, is the economic evaluation. And we've done systematic reviews, and it's just, there's no information.
Yeah, I completely agree with you. And we find the same in our works. It's a very interesting area if there are any health economists out there. I'm going to move on to another question now, and I'm going to ask Phil, please. After the discussion today, do you have any opinions about mechanisms to assess the uptake of community engagement to address global health priorities broadly? So, for example, should community engagement be more visible in global and national action plans, or should community engagement be added into existing frameworks and priorities, or any other views that you may have?
Okay, so from my perspective, again, this is I'm coming from a very specific case of community engagement. I come back to this in a second, but I think all of the above, yes, I think community engagement should play a much stronger role in the health priorities, including on a global scale. I would say trust the patient, trust the community, trust they are the ones who are impacted by antimicrobial resistance. If you don't ask them, it's really hard or much harder to assess which interventions which we should use. Assessing interventions obviously is always difficult to assess or difficult to do. So from our perspective, I think with regards to diagnostics, that we have a sea of diagnostic technologies out there. They are not used to the extent that we get rid of AMR. That we still are talking about AMR, but we have all these technological solutions. One big aspect is the user adoption. The user adoption of all these technologies. And I think from that perspective, the thinking about ensuring adoption and use of technologies or diagnostic interventions should be a main part of all these discussions, which are looking into the global health priorities. They are, yes, we are talking about diagnostics uptakes, as I mentioned, the WHO, the global AMR agenda, which has recently been published, and certainly we will hear more about this, for example, next year at the UNGA high-level meeting on AMR. So, but I think bringing in community engagement in the design of those tools would be extremely important. I keep making that pledge or that pitch in all these different events and sessions.
Thank you very much. Really interesting. I now have a question for Satya. In the last webinar, speakers highlighted the importance of regular coordination and communication with policy-level stakeholders. So what are your thoughts about how this can be carried out effectively?
Thanks, Rebecca. To go back to the previous question, just a small point I would make, I'll come to the second question now. Is the community engagement, there's a value on its own. It's like democracy. It's not necessary to measure it in terms of utility or results all the time. It's like paying attention to gender or child rights and things like that. So it's a value on its own. And in the context of health in particular, one of the biggest problems is that health traditionally and historically has been a very top-down exercise, with all the knowledge flowing from a handful of experts who actually know knowledge of what public wants. So the more community engagement you have, the better. But having said that, I think it's important to make it measurable also. But the measure cannot be about what impact you're making on AMR per se, because AMR is a very long, it's geological times you're talking about, evolutionary biology. So let's not even get into trying to measure impact on resistance per se. I think the factors that drive AMR, we are all very aware of, and that's where we can have results which can show that these factors are being addressed through our interventions. And that's where the link to the policymakers comes in. Because in order to convince policymakers, I think it's important to engage policymakers, because you can work in a community for ages and make impact at the community level also. But then communities are not operating in isolation. They're interlinked to national policies, sub-regional policies. They're linked to global economics. Availability of antibiotics, for example, if you take the latest antibiotics are not available in many parts of the world because they're simply too expensive. So it's an interlinked world. So while we do community work, it has to be very clearly part of a broader network. And that interlinkages have to be kept in mind. And I think that what is happening with the national action plans is that they're being framed sitting in national capitals without reference to what's happening on the ground. And community engagement can be a way by which we generate the evidence and the results and the platforms for people to voice their demands, which can reach policymakers. So basically, community engagement is also, in a sense, a way of community mobilization to make sure that their voices are heard all the way to the top. And resources start flowing to the community because of this engagement and mobilization. So I think there are different contexts. There are countries where, say, health ministries are very sensitive to what happens on the ground. There are countries where they just don't pay attention. So it depends on each country and each context, how much noise you have to make before you're heard, or what kind of results are sufficient. Because when it comes to evidence, there's no end, because you know that, when you don't want to do something, you always say, where is the evidence? So it's not just about the actual evidence that you have. It's also about the intentions and the context of the people in power who want to do something about it. So I'm sorry if I actually answered or not.
Thank you. That was really fascinating, and I can see that Till would like to add to that.
But I don't want to jump the queue if the others want to come in.
That's fine. Please do.
No, Satya, I think this what you just said about the listening to the communities and with regards to making these overarching bigger plans. I think this is key, really. Who drives an assessment of interventions? Assessment of interventions in AMR is really difficult, as we all know. It's a long-term game which we're playing here if we want to reduce AMR, and usually to achieve that extends the duration of funding. We have 3-5 year grants. Very unlikely that we see a reduction of AMR during that time. This is why we measure antimicrobial consumption, for example. But if you take a people-centered approach and we listen, for example, to how we can improve people's lives by changing guidelines, by changing access to healthcare and so on. So that is a directly measurable aspect, and that may be something which hasn't been considered at all when these programs are set up, or research programs or interventions policies. So I think bringing those communities in, people in, and trusting them in their assessment and judgment, what is important. I think that is a really important aspect to it. And campaigns like the Antibody Guardian are things which raise the profile of that. And I think that needs to be recognized also as a contribution to driving where the resources should be put, and not just the national action plans. So feed into the national action plans, and that informs them then. Thank you.
Thank you very much. And that just leads beautifully into my question for Diane, which is really to ask about recommendations on the best ways to communicate the successes or otherwise of these types of approaches to potential funders and policy actors.
Okay, thank you. So I've got a few points, but I don't think I'll get through all of them. I think having clear objectives and metrics are really important. So for us, we started off with a number of pledges. And when we started, we launched the campaign on the 30th of September from 2014. And we set a goal of 10,000 pledges by the 18th of November or something, or 30th of November. So linked to World European Antibiotic Awareness Day. And we had no funding. In fact, initially, I wanted it to be 100,000, but colleagues very quickly advised me that was not a good idea, and it was not going to be possible, especially with no media funding. So the importance of collaboration. But because the approach we did was to really garner bottom-up approach, people took this on, and because we had that clear objective, clear metrics, people were willing to join the mission to help us get to 10,000. So when we got to 10,000, it was everyone's success. So that was really important. And then as soon as that was done, it was very much quickly evaluating, but not just evaluating, getting the evaluation peer reviewed, because that's important for colleagues to see, particularly internal colleagues and others, to see that actually there is value to what was at that time innovative, risky. Now we put our details in a lot of websites. We've got social media in a very different way, but then things were not like that then. So that links to around that, then storytelling. So we really, encourage colleagues, and we have a range of resources, tools, and linked campaigns or activities to this campaign, Antibiotic Guardian. So the shared learning events and the awards to reward colleagues. Those are opportunities to engage with for policymakers to have sight of what's happening. We do have pledges for policymakers and chief executives. And as I was putting together the presentation today, I realized that the numbers are so low. So one of the actions I'm taking away is it's been a while since I've looked at the data now, is that actually what are we going to do to get policymakers to do that? I do know that health ministers have signed Antibiotic Guardian pledges, and not just from the UK, but from across the world, but I don't know which ones they've chosen, for example. So we need to do a bit more there. And reporting and documenting, having visual materials, and then really it's a collective goal rather than, you know, UKHSA, which is the organization I'm with, and PHE, as it was called before then, Public Health England, as it was called before then. It is a collective goal, and now we are almost at 200,000 pledges, again without, you know, media funding. So that is a big deal, and we need to celebrate that. Use multiple channels. So we communicate via the peer review publications. We use social media quite a lot. We write reports. If there are policy processes being in place, we will mention it. Although it's quite challenging for me sometimes because of the lead role I have within Antibiotic Guardian, and it's then just declaring that conflict and then trying to make sure that it's evidence-based, which is why that peer review is really important. And then adapt. You know, we're constantly adapting and learning and thinking about new ways. At the moment, we haven't got as far as really thinking about how we reach the younger audience. And that's something we need to kind of think about more. We do that through the ambassadors, but I feel like our social media approach needs to change a bit more to reach the 14 to about 25-year-olds.
Thank you very much. It's very, very interesting. I'm just going to take a few moments to ask a couple of questions from the audience. The first question is for Till, please, and it comes from Prudence Hamade. And she says that diagnosis is very important to enable clinicians to direct appropriate treatment at point of care. However, knowing the resistance profiles is also important, so clinicians can know in an area which antibiotics should be used to treat specific infections. Are you working with WHO or other policymakers to ensure that antibiotics that they recommend for treatment are effective, and communicating this to local prescribers in both the public and the private sector?
I'm not 100% sure that I got the question right, but so if I am communicating in order to recommend antibiotics which are effective, then I can say not so much. This is not my remit. However, I'm working with organizations obviously which do that, and we do have interaction with WHO. So, but it's not my specific remit. And I think the starting of the question was about knowing the resistance profile and using that information. That is really important, and this is the connection between diagnostics and surveillance. And far too little is made in terms of using the diagnostics information and feed that as a routine measure into surveillance networks or surveillance databases. So that is something which we are absolutely pushing for. And for example, also with these simple point of care tests, capture the information and store it and use it in order to inform epidemiology and surveillance.
Thank you very much. And I have time for one more question from the audience, and this is for Diane, and it comes from Gunilla Skog-Stalgren. Apologies if I'm mispronouncing any names here. She says to Diane, impressive work. If you should start Antibiotic Guardian today, how would you do it? What would you do differently? What are your lessons learned?
Thank you. That's a really good question. So I guess we are 10 years into the journey, and we have learned. One of the key things is that we have adapted and been flexible in our approach. So a lot of the lessons that we've learned, we've brought back in. If I was to start it again exactly today, we probably wouldn't necessarily use a pledge approach. We probably will mainly need to use social media a bit more in a different way. But one thing I do want to say is that my thought process at the moment is we have quite a strong level of activity within the UK, and that comes from the multiple tools that we have. But something that's constantly at the back of my mind is that, are we constantly speaking to those who are already engaged, and how do we know that we are reaching broader than that broader audience? And so one thing I would want to focus on a bit more is making sure that during World Antimicrobial, how can we measure that we are reaching those who don't even know that they should care about AMR, which is what some of the mass media campaigns do, but it's very difficult to then measure that. So probably linking this more to mass media campaigns, so that there is there's that TV campaign, for example, but then we encourage people to take an action, and so we can measure it. So that's probably the way I would want to move to next now. And a really fair challenge from Satya around community engagement is valuable on its own and doesn't have to be measured or linked to. I guess the challenge is if you're seeking funding and seeking policy, they do want to see a way to measure. And so that's a very good point. And I'm taking that back, and I've already shared that with colleagues, is how do we actually show that value, that it is valuable on its own. So thank you.
Thank you so much. We do have one more question for Till, please. And if I could request Till to give a fairly concise answer due to the time. The question is from Tiku Banda. I'm working on AMR and UTIs in Zambia, and I do agree that diagnostics of UTIs is a huge driver of AMR. How cost effective is the DOSA diagnosis toolkit?
Okay, so it's not a product yet. It's an excellent question. It's not a product yet. However, we designed it with the cost effectiveness, user friendliness, and environmental degradation in mind, and as such, it's made out of paper. So it's a paper-based diagnostic, so you can use it, and the idea is that you can then dispose it according to the local guidelines and regulations. But the intention is to have it very cost effectively done. You may know the UTI, the urine dipsticks. They are made out of plastic, and they are usually also quite, depending on the situation you are, the context you are, they are quite expensive and not environmental stable. So all these have been overcome with regards to our system. So yes, it's very cost effective, and I'm happy to follow up if context can be provided.
Thank you very much. So just from my side, I would like to thank the panelists very much indeed. It was a fascinating set of presentations and a really stimulating discussion. I'm going to hand back to Eva now to wrap up the webinar. Thank you.
Thank you so much, Rebecca, for moderating today. I would also like to thank the keynote speakers and panelists for their participation. Your experience and insights have been really interesting to bring together today. It's important to mention the great work done behind the screens here by my colleagues Andrea Caputo and Maria Prantin, who are part of REACT and Antibiotic Smart Sweden. They have made possible this great webinar and also the rest of this initiative. So thank you, guys. I think there's a lot of notes. I have like 7 papers here around. Some of the quick things that I take with me today is the need for assessment of intervention of AMR is very difficult indeed, especially when we are looking towards a long-term solution and long-term effects, right? And we need to see also the funding kind of covering that aspect of this long-term vision of it. One thing that I think several communities coming together is on the need of better data and more systematic gathering of the data that can support this measuring and evaluating, as well as Shonali was mentioning. We have been seeing today how we need pilots for measuring impact via indicators to design interventions, that we need case studies, that we also can help ourselves by starting early to plan for this evaluation, including the evaluation of processes, impact, and the quality of these interventions that we're working with. And as Till was mentioning in the end, that now on the road to the high-level meeting, we can start thinking that maybe we need to bring these conversations about how engaging communities from early on to address specific community needs and to co-create with them when we are coming up with these solutions can be really important now for the next year as well. As we are closing today's event, I would also like to thank all of you that have participated in the webinar for your attention and for the important questions that have been asked in the chat. We will take this into account for the upcoming work on this initiative. For your convenience, my colleagues are now going to share in the chat the link to the initiative's website, where you can find the recording to webinar 1, and in a few days, the recording of today's webinar. Lastly, but not less important, in the coming days, you will receive a short evaluation questionnaire about this webinar. We will be thankful to receive your feedback to help improving our work moving forward. Before closing off, I want to say something that I thought it was very powerful, brought up today here, which is trust the patient, trust the community. I think we should all go home with that in this day that we've been together here. Thanks again, and we wish you a good continued day, afternoon, or evening, wherever you are. Thank you.